kids, Andy, every
full pages of people, so that must be good. So welcome to Grand Rounds today. Dr. Jabbour is not available today because she has a conflicting meeting, so I'm happy to be the facilitator here, and we're excited to have Dr. Martina Kelly here from Calgary. We will start, though, with a land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And today, Dr. Anna Kowalska is going to introduce our speaker, Dr. Martina Kelly.
Thanks, Dawn. And it's my enormous pleasure to introduce Dr. Martina Kelly, who we tried to get in for Grand Rounds about a year ago. Unfortunately, our own clinical challenges last fall precluded Martina for coming to speak to us as we had canceled Grand Rounds. So luckily, we were able to rebook for now. Dr. Kelly is a family physician, passionate about doctor-patient relationships and medical education. She's originally from Ireland and completed her PhD through the University of Maastricht on the topic of touch in medical education. In 2022, she was the recipient of the AFMC Gold Humanism Award, and that's actually where I heard her speak at the Gold Humanism Address, which inspired me and inspired a whole lot of other people in the audience and led to me suggesting that she come and share her presentation with all of you and hopefully inspire you. So today's talk is based on some reflections about our senses, being sensible, and how both intersect to help us care for our patients. So without further ado, Martina, the floor is yours.
Hi, everyone. I'm very excited to be here. Just going to get this going. Yeah, so I'm very excited to be here, partly because I'm curious to see how pediatricians will respond to this topic about connecting and sensing, and what is it like when caring for children and their families. So as somebody said earlier, it's always a rush getting to a talk in the morning, regardless of time zones. So I'm going to open with a bit of a pause. And what I'd like you to do is to just think about this word connecting and the idea of connecting with a patient. And perhaps it's possible for you to think of a concrete example of such connection. I'm going to call it one of those aha moments where everything just flows and you get the patient and they get you, and somehow it helps things improve in their care. But my questions are, as you think about such a moment, is what is it that actually helps us connect? What does that experience feel like to you in the moment? And how did that experience impact your interactions with that patient? And did it have any impact on future care for other patients? I'm not going to ask you to share that moment at all, but just I think having some sort of concrete experience in your mind might help contextualize some of the things I'm going to talk about over the next few moments. So the outline of the talk today is I'm going to reflect a little bit on this idea of connection. I'm going to link the idea of connecting with the patient to use of our senses and the ideas of perception. And then I'm going to trouble the water by suggesting that on occasion, the idea of being sensitive in medicine is somehow frowned upon. And then I'm going to suggest that there are other ways in which we know. There's a huge body of literature about embodiment. I'm not going to go into details, but I'm going to sort of hint at the term. And then I'm going to talk about the so what. And I suppose because we're all practical practitioners, I think that's the piece which I'm really interested in hearing from you guys, some of your thoughts and experiences. So at the end of this talk, I hope that you'll be able to describe the role of your senses in clinical interactions, evaluate or reflect on the role of that in how you care for people or their families, maybe have an idea of what the term embodiment means, and then discuss those implications. Particularly because I'm coming from a medical education background, I'm interested in how thinking about the body and the senses can be maybe applied or leveraged more in terms of education. So I'm going to start by sharing my own experience of connecting with somebody. And this moment took me totally by surprise. It was what I would call a routine physical examination, a checkup for an older lady. She had a massive file. I'd just finished doing the physical exam. And she reached out and she touched my arm. And somehow we ended up in a hug. And I remember that hug because I stood sort of awkwardly, actually, because it surprised me just, and I was a little bit stiff. And I could feel her arms around me. I was so close I could smell her, and it was a slightly sort of that musty older person smell. And in my hands, she started to relax. And as we drew back, she looked into my eyes, and I'm not sure what passed, but something passed between us. And it acted as a floodgate. She sort of opened up, told me her story. She was very lonely and had a really hard life with no solid relationships in it. That moment lasted, I don't know, possibly like 30 seconds, maybe less. We never talked about it afterwards, but I cared for that lady until she died. And somehow that moment of connection impacted all the care I subsequently gave her, even though we never talked about it. And in a way, this encounter has become a riddle for me. It's what started my PhD. But my real question was not that it happened, but more, how did it happen? What was it in that moment that really connected us? And I started to think, in fact, that this was not some weird once-off experience. Perhaps it was because it was a bit more florid in my mind. But it appeared that I had many moments of connection with patients. And in general, because I'm so busy and I'm moving from one patient to the next patient and the beeper's going and I want to check the lab results, I really hadn't thought about these moments. But I have an accumulation of moments of connection, often fleeting, where something clicked and led to a better outcome for the visit. And I guess my question is this what we call the art of medicine? How does this relate to the idea of clinical wisdom or phronesis? And my reflection is that we connect through our senses. So the definition of perception is the ability to see, hear, or become aware of something through our senses. And this, in my reflections, when I've thought about my moments of connection, they're often characterized by what I call microseconds. Slight change in body language, maybe a shift in the chair or the family member in the chair, a sigh. You know, when someone just goes, you just hear it. Sometimes they smile, and sometimes that smile is appropriate. Sometimes it's inappropriate, and it's a cue to explore further. Sometimes we laugh, but there's sharing between us. And so I'm wondering, is this nonverbal communication, or is it more? And I'm going to suggest that it's a little bit more, that what it creates, or what these moments grant, is a perceptual openness to the other. So in my example, it was the extreme loneliness and sense of vulnerability that almost emanated from that other woman. And that this openness, this perceptual experience, made me curious. And so my theory around all of this is that I moved from being the objective doctor at a distance, listening to the heart murmur, measuring different things, documenting, to experiencing this lady in all her subjectivity, and that calls to my subjectivity, my sense of being a person, who I am, and that in turn created a sense of intersubjectivity. So that when we connect in moments of connection, we move from you and me, that is doctor and patient as separate, to you and me as a we. Two people sharing something. And I suggest that these moments of connection carry a significance for both the patient and the doctor. and they allow us to see each other as human beings, and they help us care for each other, maybe even heal each other. We create in these moments a solicitude that mutually benefits patient and physician. I'm going to create a second pause here, because undoubtedly some of you in the audience are going, yeah, namby-pamby, touchy-feely, calm skills, blah, sounds really great, but where's the evidence? Give me the science. And so if you're thinking that way, I think that's pretty natural, because we're actually trained. Our heritage in medicine is rationalism. And I love this quote from Descartes. So Descartes wrote, "I will now close my eyes. I will stop my ears. I will call away all my senses. I will obliterate, even from my thoughts, all images of corporeal things, or at least, for that is hardly possible, I will consider them as vain and false." And so this quote really relates to the start of what's called Cartesian dualism, the separation of mind and body. And that is actually the scientific foundation for Western epistemology. I think, therefore I am, cogito ergo sum. However, I think Descartes gets a bit of a bad rift in this game, because actually the history of seeking rationality goes back to as far as Aristotle. Because Aristotle, when he talked about the human soul in De Anima, wrote about the biological view of the soul. And Hippocrates and his students were also determined to eradicate vestiges of magico-religious thinking about the human body to introduce a rational basis for clinical practice. And so these ideas go back through our history. They're also particularly, I think, interesting in the context of the senses and medicine and women, when we think about herbalists, healers, midwives, and how their roles, which were very much related to the senses, were belittled historically. We moved from using religious relics as touching to being something that's seeing. And so the history of the senses is intimately related with how we think about our bodies and what counts, if you like, in terms of evidence. And what might be the consequences of us thinking about the senses, that they're not to be valued and not perhaps to be acknowledged in a formal sense in terms of education and clinical practice? And I'm just going to draw some of my ideas here from my own experience, is that sometimes I think this idea of being patient-centered and sensitive can feel in tension with some of the core messaging students experience, which is the need to maintain professional objectivity, often described as keeping your distance. So in a way, the white coat simultaneously is a symbol of physicianship, but it could also be perceived as a form of gentle armor, providing a mantle of remove. And over the years, I've heard students ask, how do I get the balance right? What if I get too close and fail to show emotional detachment? What does appropriate mean? And often these conversations, they seem to focus more on the risks, boundary crossings, being considered unprofessional, than the possibility of reward or success. So this mixed messaging was described rather well in a recent realist review in medical education by Bansal. And she talked about how patient-centeredness is often intimately related to the understanding of what the doctor does. Do they reach out and touch the patient? Do they sort of calm them, be present in the moment? And when these patient-centered experiences are not aligned with opportunities, they create an emotional dissonance. So they're actually disturbing for students. They create a sort of cognitive and emotional mismatch. So they gave examples of where listening becomes instrumental. And I think many of us, myself included, can be guilty of asking a question. The patient says something which actually in normal conversation would require some level of emotional or sensitive sort of response. And we go, oh, I'm sorry. And then we rush on to the next question. Or even worse, in OSCEs, we set these situations up, but students are really focused on the answer to the problem. And so they give what I call the empathic head tilt. sorry, next question. And so how are we reinforcing these ways of thinking about sensitivity? Are we possibly shutting down avenues for ways of students could encounter a better type of medicine? And so where I'm going to with all of this is that the body of itself is actually a powerful player in terms of how we interact and make clinical decisions. And yet, historically, it's sort of been seen as this objective brute force of nature. Actually, I don't even know if our bodies exist in much of our encounters and how we teach. So embodiment is a broad term, and basically what it means, it's being concerned with the lived experience of your own body. And that means that it refers to a way in which we engage in our everyday lives via the utility, the physicality, the sensitiveness of our body, and how they mediate, interpret, and interact with their physical and social environments. Embodiment then acknowledges particular historical, cultural, political, and societal frames. And these experiences are also shaped by gender and race. And I think during COVID, we've all experienced how there's been a sort of reawakening of how these different frames are really at play in medicine and deserve closer attention. And just to go back to Descartes, it's easy for us who are rooted in Cartesian thinking and biological reductionism to really think, that's the science. But there is a wide and broad social science out there, which is very rich. And I just put some names if people are interested. I'm not going to go into details about these people, but there's a rich basis of embodiment theory and social sciences from anthropology, philosophy, sociology. And there are scattered examples, admittedly, in the medical education literature that relate to this. And for me, the most influential has been this quote from Merleau-Ponty, where he says that the body, as our means of communication with the world, latent in all our experience, is anterior to every determining thought. So that really shook me, because I've always thought, I think, therefore I am. And here this guy is saying, nah, your body exists. It is the source of all information. And so I think that was a bit of a sort of rupture, if you like, in my awareness. And I just wanted to sort of share that as a sort of, sometimes you can just have a quote, which can really make you think. Okay, but let's get practical here, people. Okay, so much for philosophy, theory, social science, blah, blah, blah. So now I'm going to think and invite you to think with me about the so what of these ideas. What can you as a pediatrician take from this talk today, which may help you in your care or your working with learners? I'm going to touch briefly on 3 areas: communication and learning about communication, gut feelings, and finally, healing. So let's think a little bit about nonverbal communication. We talk a rhetoric. We have the talk of body language, facial expression, gaze, eye contact. But I'm going to suggest that although we talk about it, we don't really study it, nor do we teach it very well. Only 6 of the 36 items in the Calgary-Cambridge Guide of Communication Skills address nonverbal communication, and they do so in a very generic, broad way. In contrast, communication studies has a rich literature on ideas such as gaze, eye contact, facial expression, and how we can understand it. Communication studies would also suggest that patients will make decisions about whether or not to trust their physician within a few seconds of entering the room. So before you ever get to practice your rich list of exploratory questions, your patient will have already made some decisions based on what you look like and how you're presenting your openness to them in the room. We also know that the idea of using nonverbal communication is particularly important in relation to establishing empathy and trust. So ideas of intersubjectivity rely heavily on what we don't say in the room. So I'm just wondering if you ever talk about these nonverbal communications with your students. How much do you know? Are you even aware? Because sometimes we're not aware of what we're doing, whether it be positive or negative. Traumatized people chronically feel unsafe inside their bodies. The past is alive in the form of gnawing interior discomfort. Their bodies are constantly bombarded by visceral warning signs, and in an attempt to control these processes, they often become expert at ignoring their gut feelings and a numbing awareness of what is played out inside. They learn to hide from themselves. So this is from a book called The Body Keeps Score, and it talks about how patients have a lot of gut feelings. And there's actually just a paper published last month in the British Journal of General Practice, which talks about the language patients use to identify their gut feelings. And I think particularly of interest to pediatricians, that study looked in particular at parents' views and the language they use around gut feelings in terms of accessing care for their child when they're sick. But there's also a rich literature on gut feelings for physicians. So here, the gut feeling is described as this sense of unease, where you've examined a patient, everything's fine, no red flags, but your heart's going thud, 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 thud. I remember interviewing a pediatrician, and she says, I walk into the room, I see the sick child, and my instinct is, give me that child. I know what to do straight away. They want to help the child, but the mother sometimes mightn't be that worried. We also have this idea of a secure feeling where we've taken history, we've taken exam, we sort of feel everything fits in. This literature is mainly focused in the UK and Europe, but there's a big website if anybody's interested in gut feelings, massive EU funding around this area. And yet to date, as far as I know, little literature from a North American basis. But there is particularly a research in relation to this, in relation to identifying sick children at risk of cancer or serious illness, how we triage respiratory tract infections for children, and a nice paper from 2 years ago, which looked at how pediatricians navigate the sense of their gut feelings in relation to exploring possible at risk for child abuse. It's also become, this idea of a GP's gut feeling has also become a criteria for an urgent referral for cancer diagnosis. And so again, just because of the interest of time, I won't go into it, but there is a study looking at how we can train physicians, trainees, to pay attention and listen to these gut feelings by slowing down, by asking them to describe in detail what it is in relation to their sense of alarm, and providing opportunities and creating sort of conversations, if you like, around this idea of gut feelings. And then my final observation is in relation to this idea of connection as a form of healing. As human beings, we are inextricably linked together. Our recent experiences of loss and connection have brought that to the fore. The doctor-patient relationship is a special form of connection, where the physician's capacity to heal or make whole the patient's experience of illness creates a togetherness that has meaning for both. For connection to happen, an opportunity must arise. And I suggest that many opportunities are actually presented in our day-to-day encounters with each other, which we often take for granted. They're offered by patients, but for some reason, we do not always pick up on them. Perhaps we are desensitized. And yet when we seize these opportunities, they help us help each other, be it time, a pause, space, body language, a facial gesture, nonverbal emotional cues are portals to connection. And these moments of connection stay with us, and they help us be better doctors, recalling our own humanity. We should encourage physicians and patients to be human together. And that's it. So I'd love to hear any questions or thoughts, reflections, gobbledygook. I'm up for it all.
Thank you, Martina. That was very wonderful. Very thought-provoking too. I'm wondering if there are anyone right now with questions. Oh, good. Anna?
I have one. Martina, as I'm listening to you, so much of what you say makes so much sense in my day-to-day life, and my day-to-day observations, my day-to-day interactions with patients and families. But I don't know how to teach it to trainees. What's out there to help us teach some of this art of medicine?
So I did stop. I'm just going to share one more slide. So actually, I'll go to the next one if I can. So I wrote a paper about body pedagogics. So body pedagogics is an idea that actually originated in religion. And it is the idea that we look at the embodied experiences of learners as ways to start us thinking about how to discuss the body. So we can think about how the body is shaped and trained through institutional means. That would refer to just the simple, I'm going to call a sociological conditioning of students as they move through medical school, because they learn how to stand, if you like. There's a thing called listening gaze. I don't know if you've come across this idea, but it's how you listen to the person. Sometimes you might even have their hand on the shoulder, you're listening to their heart, but you don't actually make eye contact with them. You look past or through the patient, almost like they're sort of not there. And so there's a lot of examples in the literature which relate to how we almost teach students to shut down their senses. And obviously then we could talk about that and show them that there's a way around it. I also think by encouraging students to talk about their own embodied experience. So how did that feel? And I found in my own research that doctors actually find it very uncomfortable to talk about how they feel, because it just feels, frankly, weird, because we've almost told them that everything is in their head. And yet, if you ask somebody, the reason I asked you to think about a concrete experience was sometimes there's a levity in our bodies when we connect with patients. There's a sense of an emotional happiness or peace or something. And I think learning to pay attention to those messages that we get back from our body, be they alarm or be they negative, can be really helpful. And then there's lots of examples in the extended literature. I would say physiotherapy is perhaps one of the best disciplines for looking at some of these embodied experiences, perhaps because their own practice is so hands-on. But I think the starting point is permission giving. That's my first sort of observation. My second idea is reflect on how we experience these ourselves. So if you've had a moment of connection or disconnection, I think we can often, as experienced clinicians, identify when that happened. Sometimes we know the consultation's going well and then it bombs. And often it's because we've said something, or maybe somebody was distracted, we lost the train of thought. But trying to identify those moments and discussing them with our learners is helpful, I think. And actually, I think our learners are probably more clued into this, particularly in relation to race, religion. I think there's a lot of experience there that we have not tapped into, cultural differences. Our students experience those microaggressions all the time, and often they pick up on them through their body. So that's a very, obvious way, I think, in which we can start to explore those ideas.
Thank you. Toby.
Thanks, Martina, for the really interesting, thought-provoking presentation. And I apologize, I came a little late, and so I hope I'm not, with my question, retreading something you already covered earlier. But one of the things that you need to learn as a physician is how to subjugate the signaling from your body. So that might be, I'm hungry, I need to go to the bathroom, but I need to finish this consult first. Or that might be, I'm upset, but I need to deal with this trauma and I need to keep working, or go see the next patient. And what I think I wonder sometimes happens to people is over time, we get so good at compartmentalizing and subjugating that we reach a point where we don't even realize we're doing it anymore. So we've turned off all of that signaling that we naturally have when we start our journey in medical school. We get really good at that during residency. There's plenty of fertile ground to use those skills during your residency training. And then, and to a certain extent, you do need that to function in the role. Like, it's very functional to be able to dissociate from your emotions and just deal with the the trash can fire in front of you in the moment. But how do we then teach ourselves, our learners, our residents, our faculty, to have the ability to turn that on and off? Because I think what sometimes happens is we get really good at turning it off, and then we forget how to turn it back on, like the on switch naturally goes into default off mode. And the busier we are and the more we're kind of working constantly in crisis mode, which seems to be happening a lot in healthcare right now, the more staying in the default off mode seems to be the way to get through your day. So I apologize if this was something you talked about earlier, but any thoughts on that?
Yeah, I do. I think it's functional, but I'm also going to say, is it healthy? Because apart from patients, I think we are facing at the moment an epidemic of burnout. And perhaps we have actually contributed to that culture by failing to acknowledge our own emotions and bodies. And for sure, I totally get it. We're running a code. We need to be on point. But we also know there's a literature about debriefing after a code, and it actually can be helpful for people. And yet when people have I really hate that whole feeling where you just realize you go to the toilet and you realize, crap, I haven't gone all day, and it's almost like a relief to pee. But we don't talk about those moments enough with our learners. And I'm just wondering if perhaps we're fostering that culture. So in a way, because we are the powerful people as preceptors, perhaps we do have permission giving. And we can talk about it with our students. I know that sounds really daft, a little reflective debrief, a moment, but sometimes I'll say to a student, particularly if it's an intense conversation, maybe, I don't know, patients get angry with me because I seem to be having a lot of those at the moment. People are sort of done and they're angry and the services are terrible. And, we're constantly sort of apologizing just for existing almost. And I'll say to the resident after, say, God, that was a really intense thing. I could feel my heart thudding. I feel I'm a bit sweaty now. I think I need to have a drink of water. So again, it sounds a bit daft, almost this mindfulness of your body, but maybe it has a way that we might break the cycle. So I think it's partly we need to break the cycle, because I don't think the system has thanked any of us as doctors for not attending to our own self-care. I don't know if that sort of is a response in a way.
Sometimes when I'm listening to what you're describing, the analogy that comes to my mind is having a very messy closet. And if you want to clean a very messy closet, you have to take everything out. So you got to unpack it all. So actually you now have a very messy room, but then you put everything back, you throw away the things you don't want, and then you have a clean closet. And when it comes to education for the learners, it often feels like we're actually getting good at taking everything out of the closet, much more than we were 10 years ago, where it was like, don't even open the door of that closet. But I feel like where we struggle is showing them how to put it back. That's where I could use some guidance, some resources. So it's not just acknowledging, wow, that must have been a very difficult experience that you just went through, because even I'm feeling it. But then just leaving it that, and that, I see that sometimes that, yeah, I talk to the residents and I don't know if they're actually doing any better because it wasn't that clear how to help them to deal with what I just stirred up.
And I'm going to be the first to say that I don't have all the answers. This is sort of like a start of what I hope is a bit of a research journey. But we do know from the literature with people who've experienced trauma. So when we're doing ACE scores, for example, that actually we've avoided asking that question because we thought it would open Pandora's box. But in actual fact, for many people, they've processed or they just value the opportunity to discuss. So sometimes I agree that it would be nice to have some ideas around what goes further. How can we look at if any of this makes sense, if it's helpful? But I do think acknowledgement and attuning are important concepts that sometimes we step over because our mindset is, let's go to the next step. What's the solution? How can I measure this? But sometimes we need to pause to actually unpack what it is. And for patients that are traumatized in my practice, a lot of the time, if I simply say, I hear you, that is often enough, because nobody else is trying to even listen. And I think for our learners, they're pretty bright people, and I think they can teach us too. So I don't have the answers. I definitely think there's more work to be done. But I also think we shouldn't skip a step because we don't know where we're going, if that makes sense, you know.
Hi, I just have a question or a comment. I'm sorry, I can't get my video to work. I don't know what's going on with my computer this morning. I'm wondering if I'm curious to wonder, we talk about debrief a lot, and because I work in emergency medicine and we see sometimes things that aren't great and we debrief our learners, I'm wondering if there is a role to pre-brief before a shift. So you can say that these are things that people often can find in the shift. It's a very busy time. If you're feeling overwhelmed and you feel like you feel like that you're feeling stressed, you have permission to come and ask me questions, or you have permission to go and take a break. You really need to take a break and have a snack or have a pee. Please go do it. You don't need my permission to do that. I find that with medical students, they are very hesitant to ask for what they need. And maybe as part of it, as educators for learners, is that we give them permission earlier in what we do, because we tend not to give them permission. And I'm going to say I'm pretty much guilty of that as well. But how do we foster resilience in our learners if we don't give them permission to do that?
That's a really nice idea. I like it.
Anne?
Thank you very much. This was really, I mean, I would echo what people said before. It's really thought-provoking. So thank you for framing it for us. And I think that, yeah, just a small comment, but, you know, so much of medical training having to do with the education slant, so much medical training teaches us to be empathetic, and the sole sort of focus being trying to teach learners how the patient would feel, which is clearly hugely important, and being able to anticipate that and respond to that. But and I don't know if it's safe to say, and maybe this is the root of my question, about how we are not very good at describing how we feel. And I don't know, as a population, whether that's, you know, coming into medical school, or, as Toby referenced, sort of develops over time. But for folks that have been to counseling, it's often the first time that somebody asks how you feel, and you sort of think, never thought about it, right? It's because I'm programmed, or I work in a world where I feel like I'm quite adept and practiced at figuring out how other people would feel. Yeah. So just more a comment. Yeah, I think, but I would love to hear what you think.
I totally agree with you. I think part of it is on learning for us, because we've maybe, you know, I'm like, God, I think actually I'm 30 years in practice this year, which is sort of scary. But I think we've learned to, you know, we have learned how to shut all this stuff off. And I think one of my curiosities was when I started to do my interviews with touch, I'd say to doctors, so this is an interview about touch, you know, and I hope this will be okay. And then they go, what do you mean touch? And I was like, well, you know, touching people. And they go, oh, I never touch patients. And I was like, but physical exam? And then they would sort of go into physical exam mode, as opposed to thinking about the actual experience of skin to skin, if you like, and what that is like in practice. So I think it's also one of the challenges, just to go back to the emptying the closet piece, is that studying embodiment requires novel methodologies. It's not sufficient to talk about, you know, how we interact with each other. So I've been messing around with arts-based methods, you know, body mapping, drawing, identifying colors for how we feel, because I think our language is actually part of the challenge. The other thing is, of course, some of these moments of connection are usually silent. So thinking about silence and how we engage with silence, I think there's a lot of unlearning, but there's also many questions that we just don't, even studying this feels a bit challenging to me, you know.
Great. Thank you. Melanie.
Hello, thank you for a very poetic Grand Rounds presentation. I have a comment that I think will turn into a question, but I teach yoga and I'm a very imperfect practitioner of mindfulness meditation myself. So what you said resonated with other ways of knowing and really connecting in with our senses. One area where I've come to struggle, especially in the yoga world, is that even though Western medicine has so many shortcomings and definitely isn't always the best way of knowing, the gaps that we have seem to be an area that can be filled with people who are frankly looking to profit off of others. And I think we're seeing a big proliferation of pseudoscience, and I can completely understand why so many people would come to not trust Western medicine. But it's something that I've struggled with in the yoga community, especially. And I find it difficult to kind of both like respectfully approach that and also recognize that sometimes there is a correct answer. And sometimes people are making decisions that are quite dangerous for themselves or for their children. So just a reflection, I would love any insight you have into that about how to really hold both those worlds in mind simultaneously.
I don't have an answer. It's definitely one that I struggle with myself. And it's partly like sometimes I go, is that our fault? Because somehow it seems to me in the 1980s, something happened in terms of our communication with patients that sort of let this sort of distrust sort of foster. And so, but I mean, obviously we're living in the now and we can't really deal with what happened historically. But I think a lot of the principles of yoga, mindfulness, Buddhism, Zen, actually we could learn a lot from that in medical education. But I agree that there is a sort of fine line. And so the only advice I have is trying to be open. I mean, I think we heard, all of us probably had those vaccine hesitancy conversations during COVID. That's where it really seemed to come to a fore, I feel. So I don't have an answer. I just try and sort of hold each. And sometimes I'll, depending on the patient, maybe push a little bit, sometimes hold back or wait for the right timing. It's worrisome in one way because, of course, and I say to them, look, I come from science. I've drunk this Kool-Aid a long time ago. And I think there's other ways we can recognize things. But sometimes, you know, saving a life is saving a life sort of thing, you know. So it's not easy. I think there's always that back and forth. And that's why the decisions have to be with. It's that intersubject sort of space. It can be hard for us, I think, you know.
Thank you. Irene.
Hello. So thanks a lot for this talk. I think it's really interesting. This is not something we discuss much in medical education. And my experience is during my childhood and even during my medical education, I was taught just to, you know, refrain my emotion because that can impair my medical judgment or, you know, the way I'm interacting with people or even the classroom when I was a kid. And it took me, I would say, like 10 years to understand that first, one, my impulsions are not defining who I am. And I think this is really something that was really life-changing for me. I can be sometimes angry, but I'm not an angry person. And the second thing is also, I think it's okay to sometimes say, you know what, today is not a good day for me because of like, I am feeling this kind of emotion and I'm not able to be fully available and deal with this kind of situation. And I think it's really important for us to be honest and sometimes say, you know, I can handle this situation, so I need your help and can you please step in? And I think now I'm really teaching this to the resident and all the trainees, saying, you know, it's okay sometimes to feel overwhelmed or to feel angry or sad because of the situation. And it's just, yeah, it is what it is. And you need to learn, you know, to know yourself and be more aware of yourself and your limitation. And the second thing I really loved about your talk was about body language and the patients, because I'm doing NICU, so most of my patients, I'm communicating with them. You're just using the body language, and sometimes, you know, you just enter the room and you have this feeling of peaceful and joy. And even though you don't have already examined the patient, you know everything is fine. And sometimes you just enter the room and you have this feeling of discomfort, and even without starting your examination, you know something is off and you need to address this. So thanks. I think it's really helpful, and we have a lot of work to do for the trainee and for ourselves too. Thanks.
Thanks. Yeah, it's interesting. I gave a workshop recently with family doctors about this idea of gut feelings, like do they have them? And it was interesting. The emerge docs said they use this gut feeling quite a lot. But some of the family doctors said they'd almost learned to shut it down, because if it wasn't on the criteria for referral, even if they felt it, they tried to ignore it. And of course, now the research in the UK is saying, actually, that is a reason why somebody should have like a direct to scope sort of thing. The other thing I have is in response to your comment on emotions, because I think in Western society, the message is that emotions, positive emotions are okay, but negative emotions need to be suppressed. And that's actually, I do some psychotherapy work, and that's actually probably the source of much of the psychotherapy work I do, is because people have learned to pull themselves together, get over it, get on with it. And often it's because they have suppressed anger, sadness, loss, but acknowledging those emotions is not actually acceptable in many sort of social venues, if you like. And I think it's really important for our learners, because if they feel angry or if they have a negative emotion, again, I think helping them say that's okay, because emotions are neither good nor bad. There is no such thing. They exist. We feel them. And the other thing is they're like the weather. They move on. And so that's the sort of language I use with my learners, is that if you have a feeling that you really didn't like somebody, that they gave you the creeps, unfortunately that sometimes happens, that pay attention to that, because that can be a helpful cue. And it doesn't mean you're judging the patient. You're just feeling something, you're acknowledging it. And then by even having permission to sort of say, yeah, that exists, then they can pay attention to it. Where it goes, who knows? But I do think those, and particularly talking about, I'm putting negative in inverted commas because they're not negative, they just are. But we tend to dichotomize those feelings a lot.
Thank you. Very thought-provoking, and the questions are amazing. And apologies to the group that I called Laurent Irene. I realize it's an L and not an I, which so anyway. Any other questions from people? All right. Well, thank you so much, Martina. This has been really amazing Grand Rounds, really thought-provoking and hopefully practice-changing for people, and really opened a lot of ideas and discussion that hopefully will continue as we continue our journey. Thank you.
Thank you. And I'm delighted to be here. And if anybody wants to email me, my email is makelly, M-A-Kelly, @ucalgary.ca. Just very keen to chat about this a bit more. And yeah, like I really like your questions of, so what, how do we teach this, and how can I explore this more? So I think that's given me some helpful food for thought. So thank you for that.
Thank you. Have a great day, everyone.